Health Sciences Institute, leading the transformation in evidence-based, patient-centered care.
Now let's put some of those concepts into action, and we'll do that by looking at a patient scenario, and we'll do sort of a role play, first with a more traditional approach, just for a few minutes to see how that goes, and then next we'll shift into a more motivational interviewing consistent approach. And when we're done with those, we'll look at some of the pros and cons of each. Our patient this morning is Susan. She has been diagnosed with bipolar disease and diabetes as well as hypercholesterolemia. And she doesn't like the medications for any of these. She doesn't like to monitor her sugar and is not particularly a fan of going to see her provider. So let's see how our appointment with Susan goes this morning. First, the traditional approach. Good morning, Susan. How are you today?
Hi, Mike.
That sounds like maybe you're having a tough morning. How are your symptoms going with the bipolar disease? First off,
I don't know. You're pretty good at picking up on things. I'm not having a good couple weeks.
Mm-hmm.
I was doing pretty good there for a while.
Right, you were. I wonder if that's because you stopped taking your medicine.
Yeah, I was flying high, feeling good. Really didn't need any help, and hate those meds, and kind of threw them away.
Yeah. Well, I mean, we've seen this before, right? Where you just didn't feel like you needed it anymore, and we sort of got in the same place. That ended you up in the hospital last time, and it looks like here, from what I can see, your blood sugar is sort of off the charts. I'm just kind of wondering at this point what it's going to take for you to stay more consistent with the treatment.
Well, I don't know. It's kind of easy for you to say stay consistent. You're not the one taking them.
No. I mean, I guess it doesn't seem easy for any of us, right? I mean, we're both sort of working, hopefully, for the same thing. But I can't, I can't take the meds for you, and I can't get you in here any more than you're willing to come. And once again,
I'm just real busy. Yeah, I'm just real busy. But I'll think about, I'll think about taking them again.
Well, I'll just. I don't want to beat a dead horse here, but I do feel it's my duty to remind you that when you stop these meds, bad things tend to happen, and that's not just with the psychiatric symptoms, but the medical condition, the diabetes. I mean, I would hate to see you become another statistic, but we've seen, with the blindness and the amputations, I would just hate to see you added to that list. The cholesterol is a big concern for me. And I really would like to see you getting in here on a more regular basis.
Yeah, okay.
All right, I think Susan's probably had about enough of that. So we'll break there, and then why don't we just go right into the same scenario, the same patient, and this time we'll use an approach that's a little more consistent with the motivational interviewing concepts we've been discussing. Good morning, Susan. How are you doing?
Hi, Mike.
Hey, you sound a little down.
Yeah, I haven't had a good couple weeks.
Oh, I'm really sorry to hear that. What's been going on?
Well, I was doing pretty good there for a while, feeling really good, didn't really need any help, and, I guess I thought, you just don't think you're going down when you're up, so.
Right. Yeah, it's got to be so tough to feel like everything's going kind of how you want it, and then it sort of feels like the bottom drops out.
Yeah, you'd think I'd learn. I guess you probably know I haven't refilled my meds because I threw them out again.
Okay. So tell me a little bit more about that.
Well, same thing as last time. I hate taking them, and I just don't feel like I need them when I'm doing so well. And, I just, it's kind of embarrassing, but because now I've got, a little better perspective, and I'm feeling pretty lousy and kind of wishing I hadn't. But, to have to go in and see my doctor and refill everything, I don't know.
Well, I hope we don't have to add feeling embarrassed, to the things that you've had to go through here, and you don't have to be embarrassed with me. This is a lifelong learning process, and you had this experience before, and you were doing great, like you said, and that tells me that when you really put your mind to it, you definitely have what it takes to keep this stuff under control, and it's tough over time. I'm just wondering about the meds. My sense for before was it was kind of hard for you to figure out at a given point what benefit were you getting out of these medicines, and I'm wondering if maybe you can talk a little bit about that.
I guess it's because, you take other drugs and you immediately feel good. And these, it's kind of like nothing happens. I guess nothing's supposed to happen. But, the cholesterol, I can't feel anything. And again, I think I'm okay there. And the other stuff, I'd be willing to take that again. I know I need to keep my blood sugars under control. I can see that when I do check my sugars. I haven't done it much, but I can see that. The bipolar stuff, I obviously, now that I'm down, I want something to make me feel better.
Right. So for some of these things, it's really hard to find a good reason to do it, and for others, you have some pretty good reasons of your own.
Yeah, and I know I need to get back on my regimen, and you're right. I was doing good for a while there, for about 6 months.
Yeah. Well, if it seems like something that you're willing to take on again, let's see if we can get you back on that path, and maybe we could talk a little bit about one of the things that you think you might be willing and able to do now.
All right, I'll make an appointment.
All right. So let's stop there and just take a brief look at some of the things that we think might be considered pros of the traditional approach, and some of the things that we might consider not so beneficial. Obviously, it's something with which many of us are familiar by definition, the traditional approach, and it seems like it really cuts to the chase. It's pretty quick to address a problem and to try to identify a solution, and it really sets the stage for us to inform our patients about our perspective of what's going on and our suggestions about how they might turn things around. I think it was apparent when we did that role play that some of the things that aren't so beneficial about that approach are the tendency or the potential for that approach to create resistance, for the patient to feel like she has to defend herself in a way against what I'm doing. And what that generally does is it makes the patient less actively involved in their care, which we've seen is problematic in terms of outcomes. And it really can be frustrating both for the patient as well as the clinician. And then as far as motivational interviewing, it's basically the flip side of that coin. We see less resistance and increased activation from the patients. You could tell that Susan seemed less defensive and seemed more likely to reach a conclusion on her own that we would really like for her to reach ourselves. And that leads to, I think, reduced frustration for both the patient as well as the clinician. Some of the things that are a little bit tough, anything that's new, anything that represents a change, especially when you're feeling really comfortable with what you were doing, often requires us to step a little bit out of our comfort zone. Sometimes it can feel like we're not doing much. I'd be interested to know what you thought about the time that it took. It seemed like we were a little more conversational in the second role play, and yet I don't think it took a whole lot longer. I did get a lot more information and a little bit more agreement, a little bit more activation from the patient. And then finally, there's the sense of, well, if I'm not given a bunch of information and pointing out a bunch of problems that I don't think my patient sees, what am I actually doing? And what we would argue is that in motivational interviewing, what we're doing is setting the stage for our patient to be more actively involved in her care. This next slide has enough information to fill probably half a day of training, so we're just going to touch on a couple things that came out of that last role play. As we've seen with Susan's discussion about her conditions, there's a lot of ambivalence there. I don't like taking these medicines. They don't really do anything for me, but I know that I need to, and now that I'm down, I think I probably have what it takes to get back on track. So almost every time we work on some form of behavior change, especially in chronic conditions and the comorbid conditions we're talking about today, patients are ambivalent. They feel at least two ways about things, and so we don't want to be surprised by that. We don't want to be thrown off by that. We just know it's part of the deal. EPE stands for elicit, provide, elicit. This is one of the ways in motivational interviewing that we provide information. We don't assume that the patient doesn't know. We start by eliciting, by asking them what they know first. I think in that second role play, you may remember my asking Susan a little bit about what's her experience taking the medicine. My hope is that when she talks about taking the medicine, she'll give me some information that actually helps us with change talk, which we'll get to in a moment. But if she identifies, if we have more time with the patient and she identifies some gaps in her knowledge, I'll ask her if it's okay for me to provide some information that I hope will be helpful for her. And I'll remind her that as an autonomous adult, she has the right to disregard that information if she doesn't find it useful. And then finally, I elicit again. I ask Susan or my patient, what do you think about this and where does it leave you now? I referenced a moment ago change talk. This is really one of the keys to motivational interviewing. The goal of a motivational interviewing intervention or discussion is to hear a patient talk about some of the reasons to change, talk about some of their confidence in their capacity to change, talk about, ideally, the need for them to change. These are all on their terms. This is what the patient is saying to us. And there's a pretty good body of evidence out there that suggests that the more patients talk about these desires, abilities, reasons, and needs to change, the more likely it is that the patients will actually engage in change. Finally, rolling with resistance. You could see in that role play that in both cases, Susan really was a little bit down and a little bit defensive and grew more and more defensive as I pushed her harder. And in the motivational interviewing approach, I really didn't give her anything to push against. And that's the key here. It's not about giving in or tacitly approving behavior that we think is unhealthy, but rather realizing that it's not our job to show someone her faults or to prove that she was wrong, but rather to find a way to more effectively support her so that she's more likely to make the changes that would be better for her and that we consider it our responsibility to help her with.